Good afternoon, everyone. Welcome to the ISHLT Cardiology Professional Community webinar. My name is Clara Hjalmarsson. I am an Associate Professor of Cardiology at Gothenburg University and Sahlgrenska University Hospital in Gothenburg in Sweden. And I have the pleasure to serve as moderator for today's webinar together with Dr. Anju Bhadrwaj from Houston. Anju, would you like to introduce yourself?
Hi, thank you, Clara. Hello, everyone. I'm Anju Bhadrwaj. I'm an advanced heart failure cardiologist at University of Texas and an ICU director at Memorial Hermann Hospital here in Texas Medical Center in Houston, Texas, USA. Thank you, everyone, for being here for this webinar. Clara?
Thank you. So today's webinar, we highlight the clinical presentation, the key diagnostic strategies, and the treatment options of external outflow graft obstruction in patients with left ventricular assist device. The talks will be about 13 minutes, and after each talk, we will have Q&A for 5 minutes. So please, everyone who attends, put your questions in the chat, so we will address those questions. And our first speaker is Dr. Phyllis Billia, Associate Professor at University of Toronto and the Medical Director of the MCS program in Toronto. And Dr. Phyllis will discuss potential causes, clinical presentation, and diagnostic strategies. Phyllis, welcome.
Thank you. I am the MCS director in Toronto, and I'm really happy to present on the presentation and diagnosis of the external outflow graft obstruction. I don't have any disclosures that are relevant to this talk. So in the interest of time, I won't be discussing the epidemic that is heart failure and the use of LVADs in heart failure patients. Rather, I want to go right to the problem with a bit of background and then focus on presentation and diagnosis of obstruction of the external graft. Treatment strategies will not be the focus of my talk. We have two other speakers that will really focus on that. So now let's look back. Initially, what had happened was we had the initial results of the Momentum 3 that was published. Yes, showing that HeartMate 3 was associated with better outcomes at 6 months when compared to HeartMate 2. However, despite these superior outcomes, what was becoming evident was a category of pump malfunctions that were related to a design flaw that have been termed an outflow graft dysfunction. This type of issue has the potential to impair normal pump function. We are one of the first groups to publish a case series of this. In our case series, we had 2 patients that presented with low flow alarms and symptoms of heart failure, and this prompted admissions for both of these cases with further investigations. In both of these cases, patients presented at 6 months after the implant, and after removal of the device, we found that there was an outer layer of thrombus causing near occlusion of the outflow graft at the level of the bend relief. We thought that this was likely caused by bleeding into the space between the outflow graft and the bend relief, resulting in the occlusion. And this is really as a result of the fabric of the outflow graft being porous that could lead to leakage of intravascular contents. And then this was followed shortly afterwards in May 2018 with the FDA issuing a recall that related to what they called an LVAD graft outflow complication. So let's look quickly at the mechanics of the problem. And this is from the Abbott advisory. The HeartMate 3 is designed to allow for rotation of the outflow graft connector by the surgeon after connecting it to the pump so that the proper alignment of the outflow graft can be made during the implant without having to disconnect the outflow graft from the pump. To reduce the chance of rotation of the outflow graft or twisting, a screw ring was added, and this is shown in purple. So now what is done during the implant is that when attaching the outflow graft to the pump, a clicking sound can be heard as the screwing ring is tightened. So the surgeon continues to turn the screwing ring clockwise until it comes to a complete stop and stops clicking. This should reduce the risk of twisting of the outflow graft. However, VADs that were implanted before 2018 still remain at risk for graft twisting. There have been a series of algorithms that have been published with approaches on how to deal with obstruction to flow in patients with VADs, but the focus had been previously to pump thrombosis. And the algorithm I'm showing you here was developed by Dr. Potapov in 2016 with the purpose of optimally diagnosing and treating LVAD-related thrombosis. In regards to issues of the outflow graft, other issues were seen such as kinks, intramural thrombus, external compressions, and there were a growing number of case reports and case series that were being published. Although the prevalence of this is likely higher than what was described then, there have been some recommendations made regarding to approaches of diagnosis and treatment. And recently, there's a state-of-the-art review of outflow graft obstruction that was led by Danny Goldstein and available through the Journal of Heart-Lung Transplantation. Here, the definition of an outflow graft obstruction is impaired blood flow through the outflow graft and into the aorta. And this could be partial or complete obstruction of the outflow graft anywhere along its course. The mechanism can be endoluminal, thrombus, stenosis at the anastomotic site, or even infection, or extrinsic. So a twist, debris, kink, or even external compression from mediastinal contents. The two major causes of the outflow graft obstruction are still thought to be the twist and the bend relief bile debris that actually is present. The twist is dealt with the cliff, but we're still left with the bend relief issues. I'm showing you here some examples from our own operation, our own ORs. In the middle, you can see beautifully the kinking that can happen with the outflow graft. They're very graphic. On the extremes on the left and right, you can see the debris and the clot and thrombosis that happens within, and then you can see some external compression of the external graft in the bottom. If we look at recent publications, there is a systematic review that was actually just recently published by Patel et al. In Artificial Organs. And this is a systematic review of 13 studies. Here, the incidence of external outflow graft obstruction is 5%, with a 12% mortality overall. The largest retrospective analysis is actually by Word et al. Then this is a little bit lower down, and they looked at over 2,100 patients. Here, the incidence is approximately 3%, and mostly with obstruction in the bend relief at a mean time of 2.6 years after LVAD implant. The overall mortality here, however, is 17% attributed to the intervention. Abbott recently presented Kaplan-Meier estimates of incidence of only 0.24% at 2 years and 2% at 5 years after the implant. So with all these numbers, it's clear that a timely diagnosis and treatment is needed to reduce impact on patient outcomes. But how do patients present with external outflow graft obstruction? The most common presentation is low flow alarms. That's what we think, but that actually only happens in a third of patients. Many programs have set the low flow alarm to actually happen with a drop of more than 2 liters per minute. About half the patients, if not more, will have symptoms of shortness of breath, fatigue, heart failure. Heart failure is only in about 1 in 5, but this actually can be quite progressive and quite dramatic so that patients are presenting in cardiogenic shock. In addition to that, some patients may have dark urine, they have acute kidney injury, increases in bilirubin, and even elevated LDHs. If we go back to that state-of-the-art review, actually it shows a diagnostic algorithm which puts us all really nicely put together. So let's focus on the first part of the algorithm, and that is with the clinical presentation, because that is important, meaning understanding the acuity and the severity of the change in LVAD flows, and also having a sense of what is the degree of the residual cardiac function. The range of presentation can actually be from an incidental finding to extremes being shock or a major arrhythmia. However, in chronic progressive outflow graft obstruction, the typical presentation can be heart failure, RV dysfunction, and arrhythmias. So patients can be dizzy, have orthostatic hypotension, and even syncope. The device will have low flow alarms as the hallmark of severe outflow graft obstruction, and this can be gradual or sudden. So clinically, it's important to rule out other things as well, though. You need to make sure that the low flow alarms are not from bleeding, hypovolemia, congestion, hypertension, tamponade, etc. And some of the initial things to do are even laboratory tests like a CBC, a BMP, LDH, haptoglobin, coagulation profile, all of this keeping in mind that hemolysis is not common in these patients. And also a high LDH is more in keeping with pump thrombosis. Echo is not necessarily going to diagnose obstruction directly, but we're looking to rule out those other causes of low flow alarms, tamponade, RV failure, and you can somehow image the outflow cannula sometimes with color and Doppler signals from a modified right peristernal view. Here is a nice example in that review showing the turbulent flow at the site of the anastomosis in panel A. In panel B, you can see that the pulse wave Doppler at the anastomotic site is abnormally high. It has high peak systolic velocities. And in panel C, we see abnormally high continuous wave Dopplers of 2.5 meters per second. The manufacturer recommendations are that peak velocities are below 1.5 meters per second for the HeartMate 3. And in patients who are hemodynamically stable, you can think about doing a ramp study with simultaneously doing a right heart cath. It can both be very informative. So as you're increasing LVAD speeds, you see a failure to increase LVAD flows, or a failure to see a reduction in the opening of the aortic valve, or a change in LV dimensions and even the degree of MR. All of this can be suggestive of obstruction to flow in the graft. And if it is abnormal, the next, and you have a high index of suspicion, really the next step is CT angiography, which should be done. And from a CTA, we can now characterize the type and the severity of the outflow graft obstruction. And this is important to know. Is it a twist? Is it a kink? Is it buildup of the bile debris, or is it a problem with the bend relief? This is very important because then this leads to actually developing a care plan and determining if it should be surgical, percutaneous, or following that patient in continuous monitoring. Here are some nice examples of what happens with this on CT angiography, where you can see obstruction of the outflow graft. In addition to that, I'm showing you here on the bottom, at the time of explant, the debris that can happen, that can show up. And it's actually interesting in other types of angiography. You can see twisting of the outflow graft pretty beautifully here in the bottom right. So in summary, outflow graft obstruction is indeed a design flaw of the HeartMate 3, and you have to have a high index of suspicion in order, when a patient presents in heart failure with or without low flow alarms. Obstruction can occur in a variety of places along the length of the outflow graft, and it can lead to significant morbidity and mortality. So therefore, with all of this, keeping this in mind, really timely diagnosis is really needed, as well as continued longitudinal surveillance of both power and flow in those of us that follow these patients on an ongoing basis. Thank you.
Thank you, Phyllis, for this elegant talk on presentation and diagnostic approach to external outflow graft obstruction. I'm waiting for audience questions, but I also have a question after listening to this insightful talk. Now, you talked about the myriad of symptoms, something very non-specific to profound symptoms of shock. So I think we know what to do with like shock patients or heart failure patients, which I think Atman and Roxy are going to talk about. How about patients who sometimes we just have an incidental finding, they got a CT scan for something, and we just found that there's some debris accumulated, there is obstruction, which looks severe, but clearly it's not manifesting into anything. What is like any protocol for surveillance, any recommendations you have specifically in those regards?
So this is a very tough question because it really depends. It's patient specific, right? So it depends on how the patient is presenting and what is the degree of obstruction. And every program will likely have their own algorithm of what to do. There's really not something out there that that says this is what we should do. So if it's an incidental finding, and if it's depending on the degree of obstruction, really continuously monitoring these patients, whether it's through echo or even in bad clinic when you're actually looking at power and flow would be, and then also patient symptoms. So I think it's a little bit more complicated to come up with a simple algorithm, to be quite honest. It's very patient specific, and you just have to keep monitoring these patients if the decision on the basis of the program is that we're just going to monitor. And again, it depends on like progression. If you're not monitoring some programs, like for example, DT VAD patients, you're probably not seeing on a monthly basis. Our patients who are listed for transplant, we're still a very heavy transplant centric program. We follow those patients every month. That's probably overly aggressive, but we don't want to run into any trouble. So we're probably going to see progression a little bit faster. But if you're following DT VAD patients 3 to 6 months, you may want to change that frequency and just see what the parameters are like, as well as repeated echoes, I think. I don't know the CT angiography would be triggered repeatedly. I think it would be based on symptomatology and then changes in the parameters that you can get from other things.
Yeah, I have this comment from Dr. Tedford, Ryan Tedford. He's asking, like, and of course, like, as from CPC we discussed, that like how this is like a major problem which we've been encountering with our patients. And he's asking if, are we to the point where we should be screening CTAs on folks, say 1 year post-implant? Like, do we have any recommendations or any like, pointers about looking for them?
Yeah, it's a great question. The problem is its frequency. The incidence is still not high. to then burden the system with the cost. I mean, it's different in the US than it is in Canada. For us, we're a single payer system. I think you have to have a high index of suspicion. If you start to see that the power and flow is changing, I think that should prompt it. But the incidence is still not high enough that it should be done routinely at a year, I would think. So I think we have to see, and we have to do this prospectively to determine if it actually is cost effective. There's so many different factors. It's a great question. I don't think we have enough data to answer that at this point in time.
Absolutely. And then another audience question is something like the question I asked myself, or even my post to my team when I first saw my first EOGO. Like when diagnosed, should like this be an opportunity, not opportunity, but like, you know, an indication for us to upgrade our patients to status 3 who were like, you know, who had this LVAD for bridge to transplant?
Yeah, that's again another great question. It's not clear what the rate of progression is for this. I think for us in Canada, what happens is if we start to see that there is a change in the clinical status and the progression actually, that we start to see progression and it becomes a problem, we actually can upgrade our status by going across the country. A lot simpler for us when there's only 15 transplant programs where we can get consensus and upgrade patients. I do think that if there is rapid progression and it's you know, rather than doing a swap out, it's probably safest, right? If you're going to do the next surgery, that it could be a transplant. I actually think if there's a mechanism to then have the ability to upgrade, I think that's a great alternative rather than swapping up the VAD, or, you know, it's much messier to go in for, if it's the second redo and then the third redo, like you want to try to minimize that. So I actually do think that it is interesting.
Okay. Yeah. Thank you. That's very insightful. And then somebody's asking about difference between HeartMate-2 and HeartMate-3 in terms of the EOGO management or diagnosis.
Yeah, so there isn't a lot of data on that to actually, because it was just at the time when I think not a lot of published data. I did a bit of a lit search to kind of look at this. Not a lot of published data, but maybe our two other speakers might have more of an experiential experiential discussion around this as they're seeing the, you know, we don't have a lot of this in our own community, to be quite honest. So, but there's not a lot of published data comparing HeartMate-2 to HeartMate-3 that I could find.
Okay, yeah, thank you. Like, that's what I would think. There is another question, like, can HQ curves inform which EOGOs are clinically significant? And I would like to see, like, you know, if there's, what is the usual, like, you know, in practical purposes, like how easy it is to get all this information.
So you can get this information if you send your, you know, you can get the data downloaded and send it to Abbott and then get that information back. I've not personally found it very helpful, but you can definitely get that data downloaded and see. The problem is we have not had a lot of experience. It would be interesting to see if the community has seen that. Yeah, thank you. Ryan agrees. Yeah, I mean, we've done it and it's always not been very, we've not gotten a clear answer at all. So
very non-specific. Yeah.
Thanks, Ryan. I feel vindicated.
Yeah, but thank you, Phyllis, for this talk. Our next speaker is Dr. Atman Shah. He's an interventional cardiologist, professor of medicine, clinical director of section of cardiology, and co-director of cath lab at University of Chicago in Illinois. He'll be sharing some insights into percutaneous interventions for management of external outflow graft obstruction. Thank you, Atman.
Thank you, Anju, and thank you for having me on this talk. I promise this will be a non-data-driven talk. And I'm going to talk about percutaneous management approaches for external outflow graft obstruction from a percutaneous interventional perspective. These are my disclosures. And from a very nice slide from Dr. Kapoor, illustrating the hemodynamics of balloon pump support with outflow graft obstruction. If there's a patent outflow graft, the balloon pump can augment flow as necessary. However, if there's obstruction in his particular study, there's decreased flow. And so what are the different types of outflow graft obstruction? There can be clot, there can be an anastomotic lesion, there can be a kink, or there can be extrinsic compression. And we know from this study not too long ago, we know that the increasing risk of outflow graft obstruction can vary from geographic region to geographic region, as Dr. Billia said, and it can also depend on the type of device use, and the experience of the implanter. Clot may or may not be left up to the discretion of the management team. Certain technical approaches may be due to patient's anatomy and intrathoracic variability, and I'd love to hear some of the insights from my colleagues on this call on some of the surgical issues that come up that can lead to outflow graft obstruction. So as an interventionalist, we're just like complex mechanics. The LVAD's a beautiful machine, as illustrated earlier. It's run by incredible drivers. We're just the mechanics. So it helps to go through what we can do and what are our tools in our toolbox to help take care of some of the problems that occur. So this slide, already seen earlier, looks at the clot that can form in the LVAD outflow graft, and how can we treat that? Well, there's a couple of different catheters we can use to extract clot. And again, none of this have any data, and none of these are approved by the FDA for this indication. The first clot extraction system is the AngioJet system. The AngioJet system is designed to remove clot from coronaries, from peripheral arteries, from vein grafts, but we can also use it to extract clot from the graft. Now, this relies on a physical principle called the Venturi effect, where jets of saline are injected from the tip to the distal part of the catheter, which allows clot to get sucked in. This comes in a variety of different sizes. So why is this important? Well, when we think about what device we're going to use, and I'll get into it, we want to think about whether we want to do a femoral approach, a subclavian approach, because the length of the catheters may be an issue. Now, these AngioJet catheters are around 80 to 120 cm in length, and that'll get to our guide catheter choice in a little bit. But AngioJet is one option to take clot out. Another system we use is the penumbra system, both the CAT-RX and the coronary system. This is 014 guide wire compatible. It can go through a 6 French guide. Also really good at taking care of clots. Again, these are clots that are prior in the coronaries. The penumbra system does have catheters that are designed to take out large clots from the pulmonary arteries, but now we're talking about catheters that are anywhere between 12 to 24 French in diameter, quite large, quite big to be put into the arterial system, especially if we're thinking from a percutaneous approach, from an axillary or a femoral approach. But these two systems can be used to help extract clot from the outflow graft. Recently approved from Abbott is the Jetty system. This is a thrombectomy device that also helps take out clot. This is approved by the FDA for removal in peripheral arterial disease. I have not yet used the Jetty system in outflow graft, but the idea that it's a bigger orifice, it has greater suctioning power, it may be able to really debulk the amount of thrombus that's seen in the outflow graft. Now, when we are now dealing with this clot, we're not surgeons, we can't clamp the aorta. There's always a risk that clot can transfer and lead to a stroke. So one of the things we have to think about is cerebral embolic protection. We use cerebral embolic protection routinely, well, I shouldn't say routinely, fairly frequently in high-risk TAVR patients. One of the things that we need to do as we start exploring how we're treating these patients is whether we should be using cerebral embolic protection devices in all of our patients. Here you see a variety of different embolic protection devices designed to be deployed in the aortic arch to help protect the cerebral arteries from any clot. Furthermore, from the treatment of carotid artery disease, we have cerebral protection devices that can be placed in the internal carotid artery. Now, this would require 2 arterial access points, but this is a slightly lower profile system, a little more manageable system. But again, the idea here is that if we liberate any clot from the outflow graft, we don't want it to go to the brain. So more data to come, more ideas on what we should be using and when, and whether there's any idea of clot burden or the type of clot, age of clot, if that forces us or influences to use cerebral protection or not. Again, I just throw this slide in there. This is a ripe area of discovery, not only for outflow graft obstruction, but primarily also for TAVR and other aortic interventions. Here's an example of clot. I'm going to show a case. This is a case we published recently. This was a HeartMate 3 that had clot basically from the entire length of the graft. Putting a catheter into the graft showed severe dampening of pressure through a variety of different stents, which I'll get into. We have restoration of flow. Whoops. Oh, I'm sorry. That was out of, let me get to the slides real quick. Oh, I guess my images, I apologize. So the images aren't playing. This is an example of stenting of the outflow graft. What we did here is we used a variety of different covered stents, which I'll get into, because it was thought that if we went ahead and we used extraction catheters the clot burden would be too high. So what I used in this case were covered stents, which I'll get into in terms of how we treat it. Furthermore, there's also potential issues of anastomotic lesion. So I know we've been talking about the HeartMate 3. This was a heart wear device that had an anastomotic lesion where the graft was attached onto the aorta, in which we used a covered stent to stent that open. Again, not complete equilibration of the pressures, but close enough. What are the types of covered stents we can use? Because these are covered stents that are of a metallic frame, but a PTFE or Teflon graft that'll help trap clot between the stent and the graft so it can't be liberated. Now, what comes into play is knowing what type of outflow graft we have. Most commonly, these are going to be with the HeartMate 3, between 12 and 14 in diameter. So oftentimes these stents may be a little too small. The Covera might be a little too small. There is the LifeStream stent, which can get up to 12 millimeters. Again, these are balloon expandable stents. We can't really use self-expanding stents in these grafts because they don't have the radial strength to stay open. So balloon expandable stent is critical. The most common one we've used is the CP stent. And so this is a stent used primarily in pulmonary outflow graft stenosis and for pulmonary valve interventions in which a valve is implanted within the stent. This is a stent that can be deployed anywhere from 12 to 30 millimeters in diameter. It is mounted on a balloon-in-balloon system, commonly used in congenital pediatrics, two-balloon system that can be taken up to 30 millimeters. Now, as the higher you go up on these stents, the more it shortens. So we have to be careful that we have enough of these stents and we trap enough of the clot. And so this is an example of the CP stent, which is what we used in that previous case. Other balloon expandable stents that can be used. Now, these are not covered stents like the other ones were, but these are the stents that can give you adequate apposition if you have kinking or if you have external compression. The most commonly used one is the one on the bottom. This is the Palmaz stent that comes in 30-10, 40-10, and 50-10 distributions. This thing is ancient. This thing is probably older than anyone else on this call. This is a stent that has to be mounted on a balloon. So those great old days where we'd have to take the stent, mount it on a balloon, and then pray that it wouldn't slide off the balloon. These are all things we'd have to use. Now, one of the key parts of this is using a big enough guide to get into the outflow graft. So one of our techniques is to always get bifemoral access. We pre-close both sides because oftentimes in order for these devices to be delivered, we need anywhere from 12 to 14 French sheaths. So we want to pre-close the artery because these patients are anticoagulated. We want to minimize bleeding. So once we're in the graft, we can go ahead and advance our sheath, oftentimes a Cook 14 or 16 French sheath that can be up to 70 cm in diameter down the graft. And this will allow passage of these very complex stents. So I wanted to end up with this very nice kind of diagram and flowchart from Dr. Kapoor, looking at how interventionists should approach treating these outflow graft obstructions. One, it's really important, the pre-cath eval, check the console, laboratory studies, echocardiography. I know one of the questions in the chat was to get a chest CT. Really, really important to help delineate the anatomy of the outflow graft. And it's really important to rule out aortic root thrombus. Now, if there is aortic root thrombus, it again underlines the fact that we should be using cerebral protection devices. Right heart catheterization is critically important. We're forgetting about that because we're so worried about pressures in the graft, across the lesion, and in the aorta. But a right heart catheterization important. As Dr. Billia pointed out, a hemodynamic RAM study can be useful. Those are usually done by my highly qualified heart failure colleagues. I can barely spell ramp. Left heart hemodynamics in terms of measuring pressures in the LV, pressures in the graft and the aorta are absolutely critical. Biplane ventriculography is very important to help delineate where the potential obstruction is. Again, provided that the creatinine for the patient is within normal limits. And then outflow graft gradient interrogation, seeing where the lesion is. And after that, it's kind of the Wild West. If it's thrombus, think about thrombus extraction or a covered stent. If it's an anastomotic lesion or it's a kink, you can think about putting a Palmaz shot stents in there that's ballooned up for that radial strength. So review of our equipment, our technique, we definitely want CT imaging to assess whether it's thrombotic, extrinsic compression, or anastomotic obstruction. We definitely want hemodynamic assessment, including LV grams if renal function allows. Bifemoral femoral access with pre-closed technique to for larger bore sheaths. and to minimize vascular access complications later. It's really important to have access to 12 to 16 French 70 cm to 80 cm Cook sheets. And I also like the 12 French Amplatzer sheets that are commonly designed for either large ASDs or VSDs. These are about 80 cm in length. That comes into play if it's a shorter patient, no problem getting in from the femoral. If it's a taller patient, it may need to think about axillary approach, in which case per-close and pre-close are absolutely essential to enhance the vascular security. We can use 035, 018, 014 wires, thrombus extraction catheters, covered stents that trap thrombus, and of course, what's critically important, consultations and discussions with our heart failure team. I want to thank you for your time and your attention, and happy to answer any questions you may have.
Thank you very much for an excellent presentation, Atman. We ran a bit short of time, but I still want to put a kind of burning question. With the actual background of changing the indications for anticoagulant therapies in patients with HeartMate treatments or devices, I mean, we are more encouraged now to actually just treat the patients with anticoagulants without the antiplatelet therapy. And would you think that that would have an impact on the incidence of EOGO in these patients? I mean, and then I think about thrombotic occlusions, of course, not extrinsic in the first place, but.
That's a fantastic question, and I don't know. I think the one part that is always a tough question is what to do after we put a stent in. Because after we put a stent in, now they have to be on their oral anticoagulation, and they should also be on aspirin and at the very least clopidogrel. So now they're on triple therapy, and these patients are at high risk for bleeding anyway. So what we will do for those patients is we'll try at least a month of triple therapy. If these patients are high bleeding risk, I'll just do monotherapy with Plavix for about a month, and then put them back on their oral anticoagulant. The good news is for these really big stents, they're big. They're between 10 and like 18 millimeters in diameter. So the flow is excellent. So the likelihood of thrombus forming on the stents is much lower. The flip side is we know that thrombus forms at a higher degree on covered stents in the coronary and in the vein grafts. So that's the one thing that throws us off. But in terms of prophylaxis, I'm not sure. I'd love to hear your thoughts. I'm very curious to see what happens. But post-procedure, we try to do triple therapy for a month. And if we can't, then just Plavix for a month in addition to their anticoagulation.
Yeah, thank you very much. One single question. We don't have time for many more. I don't know if there are any specific questions in the chat. I don't see, but yet. But there was a paper in the European journal, Heart Journal, about just this item, and the authors recommended that if you have a cross-sectional reduction in the area of less than 61%, then those patients might not have a prognostic impact from making a treatment or applying a treatment. So if they have hemodynamics which are encouraging and they don't have symptoms and they end up with this cross-sectional area of somewhere in the cutoff of 61%, then we could expect. What do you think about that? Would that be an option?
Yeah, that's a beautiful study, and it was a great paper, and I think it's really insightful and important because as cardiothoracic surgeons, you know that vein grafts deteriorate at a different rate than our native arteries, and our vein grafts are much bigger, anywhere from 4 to 6 millimeters once they're implanted. And the type of atherosclerosis and the type of thrombus that forms in the vein grafts is inherently different than atherothrombosis in the native coronaries. So I think when you have a high flow state, and if you're less than 60%, and it could be even a little higher, I think rather than have a very irregularly shaped friable thrombus, it's more of a plaquing along the outflow graft. So that plaquing of the outflow graft, it's more of a smoother texture. I think it's more laminar flow than actual turbulent flow, especially if it's totally circumferential or even maybe 180 degrees. And I think that becomes really important because you're absolutely right. I think now that if we have data that's saying, hey, even if it's 50% or 61% occluded, Why take the risk of large bore vascular access? Why take the risk of thrombotic cerebral artery occlusion? And why take the risk? There's always a chance as we're mucking around, the wire may actually go into the VAD and we may have even worse outcomes. And then we're giving contrast in these patients with renal insufficiency. I think it's a very provocative paper. I think it's a very helpful paper. And I think, we have such a knee-jerk reaction right now saying, oh my gosh, there's clot, there's something bad, we got to fix it. Maybe we don't have to fix it. We need to be more judicious in who we approach the fix, especially since we don't have tools specifically designed for this.
A big thank you to you. It's really a great topic. We could discuss very much more about that. We encourage the questions to be put and we will get them on the ISHLT Connect if we want to discuss more there. And now we have to move to the, thank you a lot, to the next presentation, which is by Roxana, Professor Roxana Moayedifar, who is a cardiothoracic surgeon at the Medical University of Vienna in Austria. So Roxana, you are welcome. Please start your presentation.
Yes, thank you so much for the introduction. Well, thank you so much for giving me the opportunity to talk about the surgical view on this whole topic. I have no financial relationships to declare. So what I'm going to cover today, I'm going to give a little bit of an overview of the surgical interventional strategies, the indications for the surgical repair, the technical consideration during the graft revision or the replacement, and also the post-operative management and the preventive strategies that we have actually available. So I thought, what is the best way to start this with a case? So we have a 75-year-old male patient. The HeartMate 3 was implanted 2 years ago. Patient presents on the emergency department, shortness of breath and low flow alarm. So we had suspected outflow graft stenosis. We checked the log files and we have outflow graft obstruction in suspicion. So we do a CT scan. And in the CT scan, we can actually see very clearly here in this transverse view, the outflow graft in a second, and all of a sudden contrast disappears. Outflow graft stenosis is confirmed here. We also have another view where you can see it a little bit more clear again. Here, oops, sorry. Here we had the outflow graft stenosis. Sorry, this was a little bit too fast. So outflow graft stenosis was confirmed. So we asked ourselves, what are we going to do in this patient? And as every responsible surgeon, we did not cut the patient open right away. We are not orthopedic surgeons. We actually asked radiology for help. So we called radiology. We're like, okay, what can you guys offer us? What can we do together? And radiologists were like, guys, we got this. We can help you. We're going to implant stents. So 2 stents were actually implanted into the outflow graft, and we were all super happy. Flow was back again. Hemodynamics were okay. Everything was good. Patient went to the ICU. And all of a sudden, 2 hours later on the ICU, patient became hemodynamically unstable. We had to actually resuscitate him for 60 seconds. There was a drop in flow. There was a drop in PI. We stabilized the patient, called radiology again, went back into CT scan. And in the CT scan, we saw this picture, very clear between the pump and the there was a disconjunction in the outflow graft. There was no contrast here. We did a 3D reconstruction of this picture actually. So we had the suspicion of outflow graft twist. What did we do? What were our possibilities? Well, we went into the OR, did a surgical revision in the 6th intercostal space. It actually looked like this when we reopened the bend relief. I remind you here, it was a HeartMate 3, so we opened the bend relief, and you can see very nicely here the twist in the outflow graft. We resolved this twist. Everything was back again. Flow was normalized, and the patient was hemodynamically stable, and we were all happy again. So what are the indications for surgical repair? I mean, there is a really wide spectrum of the indications. We have the anastomotic narrowing, we have the biodebris under the OGO wrap, we have the kinking if the outflow graft is too long. But what we have most of the cases in the HeartMate 3, as had already been mentioned earlier, is the outflow graft stenosis in the bend relief. And then, of course, as I said earlier, we have the twist that has, like we also already heard, been resolved by the new design of the HeartMate 3 pump. But I think in all the cases, we have to work interdisciplinary. We always talk to our interventional radiologist. But in most of the cases, I have to say, in the HVAD, in the hardware patients, we did stenting in most of the cases in this first-line treatment. Now with the bend relief and the problems that we know, and it's very close to the pump most of the time, the obstruction, our interventional radiologists are a little bit too scared to go with the stenting. Most of the cases, we just go for surgical. We actually did a review of all our patients, and all patients, I really mean all of our patients, 347 patients. They included HVAD patients, HeartMate 2 patients, and also HeartMate 3 patients. And those were 347 patients, and we reviewed them for outflow graft stenosis. 17 patients had outflow graft stenosis diagnosed. And you can see the treatment goes in all various directions. There was one case where I did stenting first that I just presented, and afterwards for the outflow graft torsion, we had to do surgical decompression. So it goes in all directions. But what we learned from this is we really had made our own decision-making tree that helped us a little bit in what we should do. And what I want to focus on, because we heard a lot about diagnosis and everything, I want to focus on this part. We have the confirmed outflow graft stenosis into CT scan. We have no suspected other causes. Severity is over 55%. The patient is clinically stable. Okay, we can go maybe into urgent transplantation. We do that very, very rarely, I have to say. What we do most of the times, we consider stenting or surgical decompression. If patient has also the evidence of intraluminal thrombosis, of pump thrombosis, we go for a device exchange. Otherwise, most of the cases in the last few years, I have to say, we go for surgical decompression. So we go for surgical intervention? What are our approaches? Most of the time, I have to say, as I already mentioned earlier, most of the cases, the problem lies close to the pump. So we are going for the decompression via left anterior thoracotomy. If the problem is more the kinking, it's more closer to the aorta in the outflow graft and like more distal area, we actually go for right thoracotomy very rarely, as I said earlier. Full sternotomy is also done very rarely, only in scenarios we really have to maybe like redo procedures. Cardiopulmonary bypass is always standby if we have any problems, if we face hemodynamic instability. We had also some patients that we did on ECMO, so that is also something that we keep in mind sometimes. So what are our surgical intervention strategies if we decided for an approach? Most of the time we go in the HeartMate 3 patients with the splitting of the bend relief, and we actually evacuate the gelatinous biodebris. You can see this in this picture here very nicely. You can see the gelatinous biodebris here. We opened the bend relief. We always remove the rings around it. We always try to get almost the entire section of the bend relief, or at least cut all the way up so that it really is everything removed, so we can completely relieve the obstruction. We take the suction and get it all out, so also really prevent the reaccumulation of the biodebris again. Another approach that you could go for is also the subcostal approach. It's an oblique incision. This is a rather big one because it was a redo. It was not a redo due to obstruction. It was a redo because we had to do a pump exchange before in this patient due to infection. So we used a rather large incision. You can do it also, of course, also a little bit smaller, but you can see also here on the right side, you can have a nice view on the outflow graft, also on the first part of the pump, so you can really get all the way in there. And so we have the splitting of the bend relief. What are other possibilities that are very rarely used at our department, at least, I have to say? You can resect the outflow graft between clamps with graft-to-graft anastomosis. You really have to avoid the twisting or misalignment at the ends of the graft. That has to be also done on bypass or ECMO. You can open, in the case of kinking, if the outflow graft is really too long, you can open the right pleural widely to really allow this extra length of the outflow graft to reside into interpleural space. Another option is outflow graft shortening or repositioning, of course, also again, very rarely done. And then there is pump exchange, as I said earlier, if there is any suspicion of intraluminous, if there is the evidence of pump thrombus, of course, that has to be done. And then also as bailout strategy, heart transplantation. If we here have a nice picture of pumps exchange that was done on a HeartMate-3 patient, you can really see on the right side the imprint of the biodebris here on the outflow graft. Here the band relief has already been removed. On the left side, you can see the band relief. You can really see how it is built up in there, what the biodebris really looks like in this case. I'm going to skip this a little because we already heard about it earlier. We know that in case of outflow graft stenosis, the power decreases very slowly. It's like a process that happens. If you have pump in the outflow graft thrombosis, if you have pump thrombosis, we have high power. It happens with a sudden build up. So that is something that we always have to keep in mind if we go for outflow graft decompression surgically. And also, again, more in the case of our HVADs where pump thrombosis was more of a problem. What are potential complications? A little bit boring. Typical surgical complications. We have bleeding. We have ischemic stroke, of course. We have infection. We have RV failure and organ dysfunction, and also, of course, death. What is the postoperative management? Of course, we have the ICU monitoring, patient postoperative care to manage the hemodynamics, and also confirm the patency of the outflow of the flow. We have the anticoagulation management, which is definitely easier than with the stenting. We have no triple therapy. We just go with warfarin or heparin. That is definitely a plus of the surgical way. We have wound care, of course, aseptic protocol, which is, of course, we're pretty clear, and of course, monitoring to really check flow metrics and also avoid recurrent obstruction. What are the preventive strategies? Well, preventive strategies are pretty limited. We have two things that are actually presented by Ferbet al. This is also something on the left side that we can see that we do in our institution now, which are punches with a 4mm aortic punch into the band relief to really, and also by Goldstein, there has been presented an anatomical approach with the slick technique, but both techniques have the same result, the same the goal to really help the biodebris to get out of the way. Ferbet al actually presented their data with the 167 patients they had with no patient, no band relief outflow graft obstruction in the fenestrated group and 5 cases in the non-fenestrated group. The follow-up period was a little bit shorter in the group of the fenestrated group. But yeah, this is also something I have to say we really do this in every implant right now. It still has to be seen if it really is helpful. But also we know that Abbott is working on something that has already been talked about a little bit, but it's still the future. It's in the stars for that. So yeah, I wanted to say thank you for your time and for also inviting me.
Thank you, Roxana, for such an insightful talk and sharing your surgical perspective on this management. So as a heart failure cardiologist, I know you mentioned with the surveillance part, but okay, let's say surgeon has done evacuation on this outflow graft and evacuated the debris and everything. But how, after this decompression, how as a heart failure cardiologist, how will my management change as I'm seeing this patient in the LVAD clinic?
I think it's a very individual answer with every patient, but from our experience, I can say in the cases where we did the surgical management, and if you really get rid of the entire band relief of the entire section, we did not have any recurrence of outflow graft stenosis anymore. So of course, flow metrics, as in every patient, are the most important factor. But actually, I have to say we didn't see any case where it came again.
And now this question could be open to everyone, but in such a case, would you recommend any kind of dual antiplatelet? Sorry, not even dual, because nowadays we'd say HeartMate-3, we're okay after the Aries trial. But do you add any aspirin to it? Is there any benefit considering that this is all a fenestration issue? Is there a benefit of another extra antiplatelet agent?
I have to say we don't do it. We go with just with Makoma warfarin. Mm-hmm. I don't know if anybody else has any other experience, but this is our protocol.
Okay, that's very fair. And thank you. Thank you again. There was another question which was shared by an audience. And again, it's open to everyone. And if they asked if we have any experience or if you had any experience with empiric fenestration with the band relief. Is it something we've done in the past as a surgeon,
Sorry, I didn't understand.
They talked about empiric fenestration within the band relief. I think a fenestration, like, that's why this question sounded very counterintuitive to me, because if there's a fenestration, there'll be more like leakage for that matter.
Yeah,
So,
I mean, we just, what we do is this, like I already said, we just do this punch technique. The only experience that I have to say from a surgical view with it is sometimes it can be a little bit tricky with the outflow, with the bend relief, because you can like easily destroy it. But other than that, we didn't have any problems with it. We don't do CT scans or anything on the patients, like as we already said, after the 1 year mark or so, but we didn't have any negative implications after doing it.
okay. We'll encourage the audience to share any questions. In the meantime, Atman, like, first of all, great talk. You mentioned about like embolic protection devices. So how, like, is it like invariably you do it in every case, or it's also case by case basis? Because I'm assuming it adds timing for the procedure and light radiation, fluoro, whatever we're going to talk about.
Absolutely. It adds case. We don't do it on every single case. And unlike Clara's question earlier, if the thrombus looks angrier, if it looks like we can see filamentous structures on CT, if it looks like the patient's had a stroke, maybe just one carotid, then we would employ it. The TAVR data suggests that these protection devices don't reduce peri-procedural strokes. So we have to be really careful and judicious in when we use them. The other thing that can happen also is vascular access. Both femoral arteries are going to be used for either imaging or a stent deployment. Oftentimes, one axillary will be used for a balloon pump, a subclavian balloon pump. So oftentimes we're just left with one access site. So we really kind of, our algorithm is one, if there looks like there is what we call a angry thrombus, and again, a very anthropomorphized assessment of what that thrombus looks like. Number two, if the patient's had a history of stroke. Number three, if there's pre-existing carotid disease. Four, if they have adequate vascular access, then we'll discuss it with the whole team, the pluses and minuses. And the device we use most commonly is the Boston Scientific Sentinel device, or we'll use the Spider EV internal carotid filter.
Okay, there's another question. Thank you so much. Thanks, Atman. There's another question from asking about anyone screening for fungal infections when they see like this external outflow graft obstruction. Any insights on this, Phyllis? How are you guys monitoring it? Like, we per se are not looking for this specifically, but I think it's a thought since like...
It's a great thought. We don't do it routinely, but I have to say it's not a bad idea at this point in time. It's tricky, right? I don't know what the incidence of fungal infection is in this scenario. Like, there's not really good available data for it. Ryan, maybe you put it in the chat or you can talk, but...
Yeah, so we had a recent case that was humbling. Almost always this is just external compression from the area between the bent relief and the outflow graft, but we had one that looked like all the others, but it was actually in the cannula itself, and it was turned out it was associated with a fungal infection. And I guess in Danny's review, they mentioned potentially screening for fungal infections. So that's something we've added to our protocol now, where we will check a beta-glucan when we see this, and if so, maybe consider other imaging like PET to see if there's an infection related that might clue you in there could be intraluminal thrombus.
Yeah, I think we're adding it to ours as well, but there's just not enough data out there to tell us what's going on with it. Interesting fact. But if you've got a pocket that's anterior to it, and then we would tap it and have a look. I think it's kind of begs you have to have a look if it's external.
And Ryan, like, do you do this only for patients who've after this procedure, after they have this obstruction, like as more as a surveillance thing, or like you'll do it preemptively too for patients like how somebody like how you ask like 1 year annual like CAT scan, something like that, just to see.
Clara told me I have a problem with my audio, so I hope it's okay. So Brian is on as well, and maybe he could speak to it. It's something we recently incorporated into our algorithm. Brian, you want to mention?
Yeah, hey everybody. Yeah, I hope my audio is better than Ryan's. Yeah, sorry. So for fungal screening, we were certainly struck by that one patient, which really surprised us in an unfortunate way. And then seeing it reported in the literature as well led us to kind of relook at our algorithm. So we do a serologic screen for folks who have hemodynamically significant outflow graft obstruction with markers of fungal infection like beta-glucan. And if that's positive, we reflex to actually a PET scan to look and see if they have inflammation around their outflow graft. Our surgeons, we put our heads together with our surgical team with the plan that if that is true, that we would go in with a more protection centric approach to prevent embolic phenomenon, which is what happened with our previous case. When we opened, there was a massive embolism because there was intragraft thrombus. I think Ryan's earlier question about, how do we approach screening in this population in general is a really tough one. And I'd love to hear other people who are wrestling with this question's thought about, do we only screen symptomatic or suspicious patients, or do we screen everyone? Phyllis, I appreciated your thoughts about the downside of universal screening in our bad patients, picking up false positives and the burden on the system, but curious if folks have other thoughts.
When talking about that, I think that just trying to make some kind of big data analysis with this kind of problems would give maybe an insight in the factors which are associated with the increased incidence of EOGO. So if you have big data, you could look probably at that. I am not aware of any kind of analysis looking into that, but maybe it's possible to do that and just make simple correlation analysis in the beginning to see how it turns out. Is there any relation, by the way, from to the duration of time the patient has the device to the complication of EOGO, for example? That would be nice to see if there is any. I don't know if you know more than me, but I haven't seen this. If there are any relations in that way, and maybe there are other risk factors. And is there any kind of direct discussion with the producer of the pumps in order to improve some technical? Is there anything technical which could be improved in order to decrease the risk? I mean, the type of material, the positioning, the whatever, kind of individualize the device to the anatomical needs of each patient or some patients. I don't know. Maybe you are aware of any such.
I think Roxana mentioned that Abbott is working on it as well, so I don't see her on the screen now. And the other thing was so at least from my experience, I'll tell you from my limited experience, I've seen EOGO, it's little more advanced. Like the earlier, the graft obstruction we had before 2018, I think before they changed the design, it was more pretty immediate, not immediate, but pretty more early in the course. Ryan, Brian, any opinion? Phyllis, what have you seen? I don't see it within first year at least. And that's why this question the Ryan posed was kind of very provocative.
If you look at the largest study, which was just published, right, at 2,100 patients, it's over 2 years. But the thing is, there's no longitudinal data, so it's hard because it's again, it's not prospective. They're all retrospective analyses. So looking at time to event is what we really kind of have to do, that kind of analysis, as opposed to the way it's being presented. So it's all retrospective data. And the incidence is still low. Some programs are seeing more than that, but we've only had a handful of patients that had this. So in the last 3 years, we have not had any issues. So I don't know that we're doing anything differently. All we're doing is being very aggressive with blood pressure, and we've stopped the aspirin. So right there, an infection is not a huge issue for us lately. So it's interesting to see what'll happen over the next few years.
Great.
Now we have time. We kind of running short of time, so we approach the end of the webinar. So I want to thank you very much, all the speakers, to my co-moderator, and of course to the leadership of the PC Cardiology who helped put up this program, and all of the attendees. So I wish you a good evening and a nice weekend. Thank you very much.
Thank you, everyone. Great talks. Thank you. I learned so much.